Oh,
I'm
Jessica.
good. Sorry, I could not get to my mute button.
good. Well, Christine's first time on this meeting, if I'm correct.
Yes.
Maybe we can all, while we're just waiting, do a quick introduction. I'm Carrie Moss, and it's so nice to meet you. I love all things pediatric palliative care. Nice to meet you. Ha ha. Ha. We've known each other forever.
Haha. It's nice to meet you too, Carrie. Haha. Again.
I, I just have a feeling.
Well, my name is Jessica. Hi, Chris. Nice to meet you.
Hi,
So
Jessica. Nice to meet you too.
I am also a passionate person on pediatric palliative care and hospice. And I specialize specifically in concurrent care access. And I am just by trade as well a child life specialist and a board certified music therapist.
Oh, lovely. Nice to meet you. Thank
Nice
you.
to meet you. And I've been working with kids in hospice for 12 years. So this is beautiful work, and I'm so glad there's people like you that exist to do this work, and that has.
Same. Yeah. It's
Hi, Chris.
it's
I'm
Hi, Eileen. I remember
Okay.
you, Eileen.
I don't know that we've ever met in person.
Really? Isn't that funny? Because I thought we had, and you didn't
Maybe,
work at Danbury Hospital ever as something there.
maybe.
I
I've
know
known
your
your
name.
name forever. I'm at Fairfield Youth.
Nice to see you in person finally.
Welcome.
Thank you so much for having me today.
So,
Yeah, once you're passionate about this, I don't think it ever disappears.
Chris, do you know Melissa from the center?
I do not.
So, Melissa Widoft, I've been a volunteer with Regional Hospice for 16 years now, and I approached Tony Ann to ask to help out with this working group. So I'm
Oh,
very
I'm
honored
so
to be part
sorry
of
that
everybody.
I'm sorry that I don't know you, Melissa.
Well, ships that pass in the night, I guess.
I
If
guess
we,
that's true.
I had been a patient caregiver volunteer, so we may not have crossed paths, but
Maybe not. Yeah. Well, it's nice to see you and thanks for everything you do.
So I'm waiting for Tony Ann a little bit. Um, we are continuing on with our march. I think it's fair to say that one of the hardest things is really trying to focus. Like, I think we've identified so many barriers, and we really are aware of those barriers. And challenge is really deciding what are the actionable items that are within reality and within thoughtful time acquisition that we can do. So I think that's hard. Obviously, it's quite challenging to do. And so I think that's probably our next steps are really refining where we are going. Hi, Tony Ann.
Hello there. I'm so
Hello.
sorry, but we had a volunteer decide to fall and literally
yikes.
looked like a crime scene. Hit
Oh,
his head so hard on the floor. So
Wow.
we
Oh
called an
no.
ambulance because he's like, I'm not going. I feel fine. But he doesn't remember anything before falling. He just kind of fell off a chair while he was playing the guitar. And, you know, his blood pressure is 70 over 30. So
Oh.
we're like, yeah, you're going, dude.
yeah, 70 over 30 is not a normal blood pressure.
Yeah.
Not
Yeah.
good.
Yeah. So
We
anyway,
prefer
I apologize.
don't. We were just introducing Chris to the group and chit-chatting briefly, but really we're waiting for you to be able to join us.
Thank you. Thank you so much. And I just thought for those of you, of course not Jessica, or probably Dr. Moss, but for those of you who struggle like I do when we talk about doing a spa or something like they did in Washington about kind of putting, and Chris, keep me honest here, about kind of putting hospice under the palliative umbrella. Um, I still, after, no, she's like, it's the reverse.
It's sort of, well, it's sort of the reverse. Hospice is under the palliative umbrella, and the spa can make, well, we can do whatever we want with a spa, right? And,
Right.
I did a little PowerPoint that we'll do whenever you want or
Okay,
not.
so, yeah, and I'm sorry that I'm late, and I'm sure.
No, it's okay.
I'm sure well, I don't know if you need further introduction
I
or,
do
you know,
not.
whatever, or I
I'm
just,
Chris, I'm
since I'm
scattered
late,
and
just go
I'm
for
here
it.
and
Dr. Morse
dedicated.
handled it.
Go
Um,
for it. Show us, yes, share what you brought.
all right, well, it's a lot of repetitive stuff. I wasn't sure who, my audience was, but I think this little PowerPoint can be effective at helping others understand what we already know. And I do apologize. I'm gonna try to figure out how to share. Let's see. Hey, Ange.
Well, she's looking for that. If I could just ask folks to look at the presentation, look at the barriers, make sure we've captured those, because that's going to load in and add to our kind of drive the elements of the report. Also, look at the timeline, because I've got some coordinating and writing to do, but want to make sure that everybody has a chance to weigh in on things. So the other thing too, I think, Dr. Buss, we talked about getting together in early January.
So that was coming. I was hoping we could, or I would love to invite you all to join me at the medical center here on our regular scheduled time on the 7th.
No.
Actually, was hoping we could put it
Do I
to
share?
2 to 5 p.m. And I reserved a conference room, and then I can show you what's open in the new hospital thus far, and do a quick tour, and then we could just read
Yes.
person together. So it would be January 7th, which is a Wednesday. I have a room reserved from 2 to 5.
We're there.
Excellent.
Okay, I'm gonna share my screen now. If I can figure out how to do that.
If you look at the bottom, click on the share, and then it'll find what's on your screen. If you've opened up the presentation, maybe put it into presentation mode, and then
How's this? Can you
we
see
have-
it?
Yes.
You can see
Okay.
it.
So you may want to put that
That's
into
under-
presentation mode if it's not already.
And
PowerPoint presentation mode. Or at least reduce the size of it. So we only see a portion of your screen, I think.
okay, hang on.
I'm seeing your whole screen. I'm seeing the entire pediatric palliative hospice and
Okay.
palliative care, which
You can see the whole thing?
I can see that's your first slide. It's just it's not in slide mode. It's more in just but that's fine. I can see what appears to be a full slide. There you go.
Okay, that looks like the whole.
How's that?
I think it's
Yeah.
good enough. Yeah,
Is
Good.
that it?
Perfect.
it worked.
Okay, forgive me. What I lack in technological skill, I make up for in dedication. How's that? So again, a lot of this is redundant for our group, but can be helpful. So I reviewed, pediatric palliative care, which, we all know what that is, and what that underneath the palliative care piece of things falls hospice as a special sort of subgroup of palliative care. The difference right now with concurrent care for children is a wonderful thing, as we all know, but the biggest thing that presents probably our biggest barrier, other than the lack of knowledge about it, because that's still a huge barrier. The AAP came out with an article in August about the current state of pediatric hospice in the United States. And there were plenty of people that don't understand concurrent care because it's hard to understand, and because state to state it varies also. So that can be a real problem. But concurrent care allows for treatment and hospice, but it still puts that less than 6-month prognostic indicator in there. And because of that, a lot of kids who need palliative care and families aren't getting what they need. And so this came right from the article. It's hard to see, but it's the successes of, pediatric hospice and palliative care, and the challenges. And we all know what the successes are, right? I mean, we're the choir, But the challenge is, if you look, it's pretty interesting because it's unclear guidance is the top one from state Medicaid offices because nobody kind of really knows. And when I started, you know, sort of advocating for this with regional years ago, nobody really knew. And I think I probably got away with some things, you know, but nobody really knew what the guidelines are. And that still stands in a lot of ways because there is ambiguity. And some providers read that 6-month prognosis differently than others, you know, and some will say, well, if, you know, in my best guess, would I be surprised if this child passed away in 6 months or less? Not only though is it a barrier for providers, but also for families, because we know how wonderful it can be to get in there early to be able to help support these patients and families. But when they hear that it's a less than 6-month prognosis, that can be really devastating for them and actually become a barrier to getting our care in place in a timely way. And so maybe, and the AAP, again, in this article, recommends revisiting that 6-month indicator, the less than 6-month prognostic indicator, because of those things, because it's not only detrimental to sort of the logistics of it, but kids are able to get further treatment and get hospice. So technically, how do you say that to a family, you know, that their prognosis is less than 6 months when they're also trying to get treatment? So I think,
So Chris, can I stop you for one quick question?
please.
So when we talk about that and that you're saying that this article does revisit do we change the need for the prognosis being 6 months or less? Who changes that?
Okay.
Medicare?
So yeah, Medicaid. So CMS, but so the spot, so here, we'll just skip ahead here. So my next little slide, I only have like 5 of them. But so the potential solutions, so the AAP recommends reconsideration of that 6-month prognosis due to the unique, excuse me, the unique needs of this population, right? So what can we do? We can provide education and we really need to. I was always surprised at the level of just the lack of familiarity with concurrent care, the lack of understanding what it actually is, what it means. There are plenty of agencies even out there who don't understand it at all, who don't provide pediatric care because they think that they won't be reimbursed for it. There's a million different, obstacles like we know. So educating not only providers and hospitals and all of that, but families and patients, and helping them understand that hospice isn't, a 4-letter word for their family and child. And again, by removing that 6-month prognostic indicator, it really broadens and softens everything, So the SPA amendment is actually what they're recommending now. There are several different states that have already done several different things, but Washington State has a SPA amendment, and that's my next slide here. Oh, it's hard to see. I apologize.
And you know what? One other thing, Chris, and I'm sorry to interrupt again. I
No, by
always
all
say to
means.
everybody, like at work, I'll walk into a meeting and I'm like, I'm sorry to interrupt, but I'm interrupting.
No, I'm glad you're interrupting. I appreciate that. I welcome that.
Just so you all know, I've been having some meetings behind the scenes, and with Melissa to take really great notes, obviously, with some of the people from the Solomon Center, from the Yale Law School, and really trying to get to the guts of all the things we know we have to do, but try and put the whole container of legislative changes together. And what does that look like, and how do we even approach it? And so that's when I said, for Chris, because she really understands that spot, that it would be good to go over this. So I know some of this, like, we know, but I still struggle with the understanding of it. So with that being said, we actually just met with the Solomon Center yesterday and went over legislative changes versus what is law versus, addendum versus whatever. So I thought this would be great to hear. So I just wanted to tee that up for you, Chris, while you go on.
Thank you. So the SPA amendment that Washington State has put together through the EPSDT is that they have arranged it for palliative care to be with hospice. So right now, the way things are in Connecticut, excuse me, if a patient say they need palliative services, say they are newly diagnosed and there is treatment and there is hope for longer than 6 months, but yet there's also an understanding that perhaps this illness is, causing symptoms or potentially life-threatening. Well, what Washington did was they have a separate section now of palliative care, pediatric palliative care. And what that is it consists of palliative care contacts. So they get up to 6 of these contacts a month. And this is all underneath the hospice and umbrella so that this isn't home care, because you can't have home care be palliative care. Patients can't be on, help me out here. I'm struggling. When you have concurrent care, if you don't have that 6-month prognosis, you're just going to get home care services, but they're not palliative. There's no specialized palliation care or symptom management or hospice centered care in that. And these patients might need that. They can't have that unless we do something like this so that it broadens the spectrum. Because right now, as it stands, it's either or home care. They can get home care services and hospice services if they've got that less than 6-month prognosis, but they can't get hospice services without that. And so they can have both. Patients on hospice can have hospice services and custodial nursing. Often, if you can find nurses to provide that care, it's often very, very difficult to find that, but they can exist together. But if a patient isn't eligible for the concurrent care benefit, then really there's no specialty care at all. It's home care they're getting, home care. And you can't have both unless there's that 6-month prognostic indicator. What they did was they took it a little bit further, and they said, well, we're going to have this to include pediatric palliative care services. So that means that for Washington's concurrent care, it also includes these pediatric palliative care services for patients who have a life-limiting diagnosis, but not necessarily a less than 6-month prognosis. They may not. When they do definitively, then they can transition to the actual hospice services. This is almost like a little bridge that they've created to that. And the nice thing about a SPA amendment, which is now, like I said, what the most current recommendation from AAP is, because in a SPA amendment, if a state adopts a SPA amendment, then it's independent, or it can be made independent of the Affordable Care Act. And so in this very uncertain political climate that we live in, we can potentially, with a SPA amendment, solidify concurrent care, palliative pediatric care in the state of Connecticut, completely independent of the Affordable Care Act. And so that way it can carry on no matter what happens to that. So that's a big, I feel like it's a pretty important piece of things. And so what the pediatric palliative care that they did in Washington State, they have these 6 contact hours a month, or 6 contacts. And one of them is a nurse visit or a social worker visit or a therapist license visit. And that's for pain and symptom management or psychological counseling or education and training. And then 2 hours or more per month of case management or coordination services, which includes the things that I have listed here, psychosocial counseling, grief support, planning things, care planning, those things. So they get 6 of these visits per calendar month, and Washington State and this has been a good segue to hospice care, because patients can get this and receive curative treatment. if they don't have a 6-month prognosis or less. So this is how they've done things. And there are other examples of different states, but I really feel like this one is pretty much the most comprehensive. And also it really affords help to the most clientele because you know, Carrie, that some of these kiddos don't ever have a terminal diagnosis, but they still need palliative care. And this opens up these services to children like that also.
Okay, so that's, yeah, I mean, and I don't know if anyone else has questions, because so when you say that concurrent care is different in every state, does that mean it's different in every state because of the private payers or?
No, I mean it's interpreted differently by every
Oh,
state.
okay.
Yeah,
Okay.
and so each state has its own sort of guidelines, but nobody really does have guidelines. Everybody is sort of, you know, wishy-washy about things. And that was really the case when I was doing it too. You know, even, you know, like you know, I said before, I might have gotten away with some things, you know, because it isn't clearly defined, you know, and I will always push the envelope when it comes to, you know, helping these kids and families. But what we need are clear, consistent, compassionate guidelines, right? We need them to be family and child focused. What they found in this article, which was brilliant. Did anybody else read this? It was in the American Academy of Pediatrics in August. It's the current state of hospice care in the United States and pediatric hospice care. And it really, you know, went into pretty great detail of why this can work and how this can help. Because again, there's not even, if you look back to the graph that I added, there aren't even clear guidelines in CMS. Like nobody really nobody's getting clear information. And so without that clear information, people don't know how to provide and stay within the regs, right? There's a worry about not staying within the regulations and then, you know, getting into all kinds of trouble. So if we can clearly define these things in our state and make it clear, concise, family and patient centered, then we could see these programs grow exponentially, you know,
Mhm.
just by having some guidelines that make sense and that everyone is aware of.
Well, usually that's the mode of operation for CMS, right? Never be too clear
Yeah, yeah, yeah,
or concise.
yeah. So the way
So,
the way we would do this, we would, you know, look at drafting their forms online, you know, to draft, but then it's the DSS, Department of Social Services, the commissioner would need to actually apply for the SPA amendment through Medicaid. And then it's not a very long process. Once that all starts, it can move quickly, you know, and then, you know, we would have a pretty amazing thing here. And so Washington State gets reimbursed on a fee schedule for those things. That's how they do the reimbursement portion of things. So it's not a hospice rate of pay during that period, but it's a specialized, you know, fee for service, I believe, but there's a special schedule that they've come up with based on, you know, whatever. And then they've come up with that fee schedule so that that's how that's billed through that.
right, which is interesting because, right, you get your per diem rate for
Right.
hospice and you get one visit a month. I'm talking adult palliative. One
Right.
visit a month, or I mean, I think you can do a social worker visit too, but it's, you know, to get 6, and if they were a little bit higher than they are, and the fact that it can be a nurse or a social worker, that is really helpful because as far as I know, with adult palliative, it has to be an APRN.
Yeah, I think you're right.
Yeah, so
But you
the
know, we
pediatric,
could make this what, you
right,
know, this is just an example. So we could take that and sort of run with it. And I mean, we could technically even just remove the term 6 month or less. We could, you know, we could think about all different ways to create a spa that would potentially help the most patients and families in our state, you know?
right. right.
There's questions. It looks like Jessica's hand up was up first and then Eileen.
I mean, my question, I think, is more of a discussion statement, just that I think these spas can be an incredible asset to be able to have, especially as you mentioned, in protecting a lot of those care services for children, independent of other federal mandates that may continue, may disintegrate, may change over time. I think one example of an amendment that was added in another state in Florida is really a consideration about the true scope of services that can be offered outside of that hospice care plan. Just because it can roll very quickly down a hill out of control. And I think that having something in the spa really allows us to be able to help control some of that a little bit. But one thing that I know, again, that other states have really had, I wouldn't say an issue with, but it has just caused a barrier for access, is that families do get very comfortable with that palliative support. And when it is time and it is appropriate for them to move over into an escalated hospice support, it can be challenging because they really feel like, okay, but I have what I need. So what is the benefit of going into a hospice model of care? And then it puts, unfortunately, I think the organization at risk of being able to sustain those boundaries of visits, and the staff having their own, I think, just difficulty with being able to also maintain their boundaries, and potentially falling into that risk of guilt or whatever, right? Because that conversion isn't as easy to happen. I still think that it makes a lot of sense to have something that helps protect those services, regardless of the prognostication guidelines or anything else that might be going on. But in relation also to concurrent care, just wanted to bring up that point as well, that the guidelines, I think, and I think we talked about this in previous meetings, that we were given this beautiful door with no doorknob, right, to open the door.
Right.
And this can be really helpful in some ways, because the minimal guideline that was given does allow for states to have a little bit more control on what they're able to work with when it comes to concurrent care. So we do have states that are a little bit more lenient. We have states that are willing to engage in conversation to help streamline some of those access to services. I know that in our area, in the DC area, it's very much we see the good that you're doing. We see the benefit. We're happy to work with you. Let's make sure that we're protecting some of that language in our own MOUs, for example, and making sure that we have clear guidelines in that way. But I know in other states that sometimes they can fall really hard and fast on that 6-month or less prognosis, and it doesn't matter if they're getting concurrent interventions or not. So it's really all to say that, again, I told you this is more of like a statement of discussion, not so much a question, but I think it's all to say that having protective language in anything that you're trying to pass from a state-based perspective is going to be helpful, especially just in establishing services. But I do think that having some ambiguity can be helpful, because it does allow us to be able to have more individualized conversations where things are happening, and we are able to keep some of those doors open for access to care as well.
Those are excellent points. Thank you.
Eileen, you're next.
Chris, thank you so much for this information. Really helpful. I see it as supporting families that have children with genetic issues that may benefit from palliative care over a longer period of time, especially at the point of diagnosis.
Yeah.
So thank you for that. And Jess answered one of my questions, because I wondered what the downside was to this. So thank you for that information. And third, I was wondering, Tony Ann, what your conversations with the Solomon team has resulted in. I know they had presented in the white paper spas. Did they look at Washington State, and is there any update to, I know they were also looking at Massachusetts, their arrangement with palliative care. So I was wondering if there was more information regarding a spa versus something different.
Yeah, and Melissa, jump in here anytime because you were on there yesterday and you're a much better note taker than I am. I think really what we were discussing was what would be the method, like what would the model look like if we were, to say, okay, we want to change the criteria or we want to change this. What would be the step by step? Would you have to like put in to do an amendment? But we didn't really touch on what it should be. Or like, I mean, I know we did talk about that. Obviously, they have done things like this, in other states. We didn't exactly pick apart any of those other states and what they did. But just how do we even broach the idea and how do we get our arms around anything like this? And, again, I feel like we're always at the point where it's, well, we could look at this, we could look at that. And, yes, Massachusetts did it this way, but we need more time. Like, we need more time to figure it out. And, what kind of came out of the meeting to me is something that Barbara Cass said, who I think is on here. My things get
Yes.
cut off. Yeah, there she is. Is how do we get this to be an advisory committee or like an advisory council that doesn't have so much of a deadline, but that can continue to work on certain things and not be, well, we give in this report and then, we're looking again to get, put in for another 6 months or a year. But I see Elle is on, so maybe if Elle, the studies of other states and what you all might recommend as the best, that we possibly follow, if you can, or if you need to get back to us, that question that Eileen had.
Hello, and I'm sorry for the delay. It's one of those days. So I just hopped on. I will watch to make sure that I'm all caught up, but just one of the things we talked about yesterday, also that my colleague Eugene brought up was just the idea of putting together a menu of options. And I think that could fit in well with also requests to turn this into an advisory committee that is longer term. And one of the reasons why at least Eugene and I are fond of the menu option, even though it does kind of push the goalpost down a little bit, and we're still kind of, the road keeps getting longer, is because a lot of these options, there's no one great option, as we all know. And what option would work best for Connecticut really depends on what the end goal is. So, whether this is something like, for example, is the ultimate like super ambitious end goal to say that we're going to have comprehensive care for all children with all sorts of health needs, regardless of whether the illness is life limiting, and are we looking for something that's cohesive throughout, for that entire patient population, even if it means that certain children with particular health needs may not get exactly everything they need if we can't have something perfect. Or is this something where, on the flip side, whether the super ambitious goal would be like, no, there's a smaller patient population of children with life-limiting illnesses who need and have not received for a very long time, very targeted, specialized care, specialized attention. And it makes more sense to focus on these children who were often left behind, even if that means that we're not going to be in a position to have this broad coalition, potentially with other advocacy groups with children who don't necessarily have life-limiting illnesses, but have some health needs. And so I think Connecticut just put together an advisory committee. I believe it was for children with autism with high support needs. And so that's kind of what I'm thinking of, is just in terms of coalition building, kind of broad, and we lose some depth, or it's depth and we might lose some breadth. And I think the model that would work for Connecticut is going to change depending on decisions like that. Like, what is the super big, like not perfect, like still sort of practical, but an ambitious end goal. And I think that we can come down from that and then start to decide like what steps would go into place. So just to wrap up, to put a point on this, is I think if for like a broader coalitional model where it's like, yes, there absolutely is hospice care, there is concurrent care, there is palliative care, but it's a little broader lens. Something like that might mean, building out or even thinking about like a massive waiver, pending what's going on in the federal government, like even an 11 demonstration, something like Vermont has, which is just for everyone. And maybe there's something in there, something a little narrower, then, maybe we're looking at, it might make more sense to move forward with like a private insurance payer mandate and saying that we have this collection of services we know works for this more defined patient population. And we're going to focus on that to try to functionally get rid of the 6-month requirement. And that would be more focusing concurrent care. So I think, yeah, just that top line, like super ambitious, guiding inspiration would also help determine which of the menu options would make most sense. If that all ramble makes sense.
Yeah. I would also say, to tie into what Tony Ann said and Elle said, whatever we do is going to be a phased approach. We are not going to solve this in the next year. So even if we come up with a menu of options, a tiered system, we may want to decide what are our priorities. The first tranche, it may go to kids who have extreme care needs and extreme health needs, and then over time expanding it. So, and this is one of the things we'll have to refine upon when we go into our January meeting, like putting forth a proposal and here's what we're going to recommend. Obviously, too, there's going to be costs involved. And so what is the Assembly willing to fund, whether it's year 1, 2, 3, 4, 5, in this tranche? And we probably as a team have to decide what's our highest priorities, what do we think are the things we can accomplish best in the short term, and then long term, where do we want to go? So I think this is not a short-term solution. And I think there's a lot of different ways we can make this happen, but I think it's a matter of, us as a team putting our expertise together to make sure that we're addressing all the complexity, considering what types of things we think are the highest priority, and then making a recommendation to the Assembly. Here's how we recommend accomplishing this. So.
Which if you saw what Melissa had sent out, one thing to bring up today, and I know we only have about 20 more minutes, is data, right? I mean, we always go back to we need the data. I was saying yesterday that I'd love to be able to look at all the different diagnoses that you could potentially look at a child who is not going to live to adulthood, right? And then what's the data in our state for length of life? Like what are we looking at when we're looking at certain diagnoses? And then, because probably how I see it, and we're probably going to start doing it here at Regional, is whether we provide palliative and hospice, to me, is like just gives us our payment structure. And then changes to what we're going to be, covering from medical supplies and medications once they come on hospice. But when you think about changing the care team from palliative to hospice, well, what if it was the same care team from palliative to hospice, and it's the same nurses that are either seeing them those 6 times that month, or then, whatever it changes when it goes on to hospice. I think that, again, I just always come back to that champion care kind of model, but I just might be like stuck on that. But I think Elle and Melissa, how they're saying we need to be able to offer the recommendations, how we think we're going to phase it in. And with that, I think we have to put in the recommendations, because I don't want to surprise anybody. Like, if one of the senators think they should know, if we're thinking about, going for a spa or something like that. So I kind of want to have a complete proposal, and Dr. Moss, you keep me honest here now. Not that these things are all going to be done quickly, but can eventually be rolled out. But I think we should give them a heads up now if we're thinking of something legislatively, whether that's in 6 months, next year, or whatever.
I think probably Peter could give us advice on this better than anybody about what's the timing and the sequence for putting something into the queue with the assembly. And I'm sure they have a very, very closely monitored schedule. So to Tony Ann's point, whatever we propose has to be part of the recommendations we have. Also, the concept of data, all of you, I'm sure, in this team have written reports before, and everybody goes, why should we do this? Well, how many people are affected? What are the numbers involved? Because the bottom line is we do need funding to do anything, regardless of what we recommend to do. So we need to know what are the sources of data, how many people involved, how many children involved. Also, if we have 5 different sources of data, are they all using the same information? In which case we have to kind of parse out what are the sources. So there's a lot of things behind the data that requires a little bit more finer focus. But we need everybody's help to identify where do we get these numbers. Because at the end of the day, I mean, one of the things Senator Anwar wanted to know is how much is it going to cost us? And, how do we prove this? Which is probably going into an assembly discussion, a legislative discussion. They want to know just the basic facts.
So when we think about what we're really going to put forward here, what we're trying to put forward here, is it right to think of it in terms of like the Champion Care is a package that looks at how we educate and empower people to take care of patients? And there's probably 2 prongs. One is primary pediatric palliative care, where you can empower those. You empower the frontline people that are taking care of children, period, and then you empower the specialists that do palliative care. And I think that's a big bucket of what we're looking at, is how we train and educate people in the state. The second bucket I see is the waiver, right? Looking at a waiver opportunity and what a spot can look like in the state of Connecticut. And then the third piece that has to be included in this still has to be how we meet the needs of the actively dying patient. So when you talk about like the pie in the sky, I think we have to remember or for me at least, this started as children are not able to die in their homes because we don't have the resources. It's so much so that if a child dies in the home, we have to have 911 bring them for pronouncement in the hospital. And that is a level of care that is not acceptable. Like, that is just not acceptable. And I still go back to, and I think about what we're doing here, we're trying to ensure that every child can die at home with some level of support. Mm-hmm. And that's really, so when we talk about the large group of every child in the state, that's beautiful. But I would still like to know that at the end of 2026 or 27, that no child will die in their home without some source of support and the opportunity to die in their home and be pronounced in their home. That to me would be a huge win for our state and something that we've never been able to provide. So I kind of see those, as I'm thinking about this kind of how we prong this, I think that we can't leave our mind off the mark of how we address the immediate need of dying and the children that are actively dying. And then the SPA, which allows us potentially to encourage all of this. I still think there's a fourth piece that is the workforce. Who is going to be these people? Mm-hmm. Who are going to be the agencies that are providing some of this care? Because the waiver is beautiful and wonderful and can create an opportunity, but you actually need the agencies to be willing to take part in that opportunity, if that makes sense, to cover the state. So I still think that's the next level, but I don't know. Does that make sense how I'm thinking through this a little?
So Dr. Moss, I've been kind of pre-writing a lot of the things, pulling in all the elements. And I love the fact that you focused on the care at home and the need for services and care as children so they can die at home. There's other elements in this, but we're including all of these things that you're talking about. So
I just don't want it to be so big and so cumbersome that it becomes a beautiful document that gets no attention or funding.
Right.
Yeah. Right. So that I think that's part of my worry, is we're just making sure we focus on the tangibility that asks for something back for us to be doing this work, because none of us are being paid. This isn't our job. And so this is the passion project for me. And so in that passion project, how do we keep doing this work, and how are we going to set up a structure that makes this work?
Right. And I think part of trying to figure that out, right, is, okay, how many kids are unable to die at home? because they're not on service? Where are they? And then do we even have, you always get and listen to and I get it, because it's very compassionate care to actually pronounce, right? When you haven't been involved in any care with this child and the family. But really, if you put that aside, if a family is open to someone that they may have met once or twice or whatever, coming into their home and pronouncing their child, which would be a nurse, right? If they're open to that, then how do we get that to happen? And what does that look like? And where are all the different points that we can provide that kind of care, because the state is big. And so I think that would be something like, when I say like a phased in approach, how do we, like we did from the beginning, how do you, eat an elephant? I mean, whoever wants to do that, but one bite at a time. And like, is that the first part of this phase that we look at, and then do another and another and another as we go out? But yes, the low hanging fruit, and I don't mean to call it low hanging fruit, but if that's what it is, to help a family to not have to call 911 and be brought to the hospital for pronouncement, then that may be the kind of program where the family also has to be on board, that they may not have met the person that's going to come into the house and pronounce their child. So, I think that's something that we should do as far as rollout. The little things that we can change, without doing a spa or this, that, or the other thing. I think those are the things that absolutely should be like first on the list and a priority. And then, how do you get people to do that? Or other, agencies all around the state to help with that. So, yeah. Oh, I see Barb and Eileen up there.
I just want to jump in real quick. And Dr. Moss, I think you have set up beautifully the work plan. You have 4 work streams. I missed the first one. I'm a good nurse and wrote 2, 3, and 4 down, but I missed the first one. But I think
was the
first one,
champion concept, was the whole concept of the champion project that allows for both primary and secondary palliative care. So palliative care being done by specialists and palliative care being done by everyone who takes care of children.
so I think those 4 elements are the work plan that need to be done as you proceed. And again, because I'm a nurse and I'm an old nurse, and Professor O'Shea, please be very proud of me when I say this. I think we could, it would be really relevant to apply the whole nursing process to each one of those work streams to identify the problem. And that's not why I originally raised my hand, but I think you've set it up beautifully for the group to proceed with those 4 work streams. But most important, I think, to this, and I'm going to go back to what Melissa and Tony Ann have said, is data. You need the data to demonstrate why do we even need to do this as a state. And this is where I think sometimes I can be a little bossy, and I'm going to step outside of my boundaries a little bit. But I think all of us need to the extent possible, maybe take a piece of this. I've already written down from Melissa's slides where I think I could find some data. But I think that Melissa and Tony Ann and Dr. Moss cannot do this alone. This is really a working group project, and there is lots of rich data in the state. So I'm committed, Melissa. You sent me an email. I'm going to work with you, and I'm going to see what I can come up with the data sources that I know that are out there. And I know DSS is also a very rich source of data because of the number of clients they serve, Husky beneficiaries. And they have this amazing, they can data mine in minutes. It's just incredible. So I think reaching out to Jasmine and my gosh, I think I'm having a senior moment. This will be the first time. Regina Owosu. They'll be able to help with the data. And that's how you set up the report, the legislative proposal, and how you demonstrate that, yes, indeed, we have a problem. And when I hear the 2027 goal, it still saddens me, Dr. Moss, that we have to even set a goal that no child will be in the home without support and at the end of their life. But I think we can achieve that. And then to that end, I just have a question for Chris. In one of your slides, and I apologize for coming on late, I was at a person-to-person meeting and had to run.
That's okay.
Can you help me with developing state regulations? Is it DPH regulations or is it DSS payment regulations? And the reason I bring it up, and forgive me because many of you have heard this a million times already, the time is so critical right now because we're doing our hospice regs. And I just had a meeting at 11 o'clock, mentioned again that we need to address pediatric hospice, still looking at that. But was that the intent, Chris, that DPH develop regs, or was it a DSS payment regulation specific to the spa?
So this particular spa amendment would go through DSS.
Okay, and the regulations with the spa amendment. So they would be DSS payment regulations. Okay, that helps me.
So. I believe
But
so.
again, any thoughts anyone has about what, even a wish list as to what you would like to see in the regs, just send me an email. A quick thought doesn't need to be formulated so I can start. And I'll do the formulation as it relates to the regulatory process, but the concepts, our group is open to addressing pediatric hospice. And again, that's the DPH group and it goes to another area. So we always hope for survival when we move on.
And I think that's key. And Barb, I owe you, after we met with some of our nurses, I have to focus specifically now with our pediatric nurses, and maybe Jessica too will join us, but we owe you, like, what would we be looking for from DPH about regulations for pediatric hospice?
So just concepts, even, 5-word concepts, and we'll work on it here to see if we can fit it into the regulations. And also with the workforce issue, again, I think I mentioned this to Tony Ann and Melissa in a separate meeting, but this might be a perfect synergistic time to partner with the palliative care group and look at certification, because there are 14 pediatric APRNs certified. I know that from the report, Eileen.
Barbara, that's because of the Canaric Center. I have been pushing that for 3 years. I just have a really quick question to Carrie. At the Governor's Council, the whole pronouncement issue in the home, has that never been brought forward to the APRN group?
I don't know. I don't know if that's specifically brought forward to the APRN group.
Okay, I'll find out. Thank you.
Yes, I don't know that specifically.
I have a link from the article that I referred to, and it gives state data, individual state data. And is there a chat room I could put that in, or where can I put that for all of you to look at?
I don't think we have chat, Chris, on this. Some Zoom state apps have it. I don't know if this one does, but if you send it to Peter, you'll be able to send it out to all of us. I
Okay,
think.
I will do that.
Jessica.
I just wanted to say thank you, Dr. Moss, for kind of quantifying all that information to those 4 pillars. And I think they all feed very much into each other when we think about ways that we can help families not be alone in their home. We think about setting up those supports for them so that they know who's coming into their home, and they are introduced to this concept of being able to choose what their goals are and be able to identify where it is that they want to be and how to make that happen and have that support. And when I think about the amendment or just in general protections that can be put in place for these families, I do think about helping protect their right to choose their own goals. And I think that's so important for them to have access to. And I do think that by allowing there to be more provisions and protections in place that are in a clear, I guess, expressed in a clearer way, that I think more agencies, more organizations will have increased confidence in being able to care for children. I do think, and I think, Chris, you mentioned this and highlighted this, that there might be barriers to agencies providing care for kids because they are too afraid of that prognostication aspect, or they're concerned about how they're going to be able to provide support to their staff who aren't trained in pediatrics. But by adding in extra provisions to help with something, whether it is like a funnel program through palliative care, or it's and maybe an incentive, a daily rate incentive that increases with children because their needs are higher, or by extending that prognostication to a year or changing the language so that it is a little bit more concrete, I think that's going to help quite a bit with expanding some of those services. And then I think just the ongoing education is going to be vital. But I agree with you. I think at the forefront, that is the goal. And it's all these other pillars that are helping support that foundation. So thank you for just bringing it back to that. I think that's so incredibly important.
Well, you guys are so kind. I'm just going to sit here. The girl needed on a Wednesday.
Well, you can't sit there much longer because Peter's now going to tell us it's 2:00.
2
And
o'clock.
we're losing our platform here. But again, thank you all. Thank you, Chris.
Thank you.
This is just amazing stuff. And Barb, I'm going to email you a question so I understand regulation. And then more to come. Thank you, everyone.
Bye, guys.
Thanks, everyone.
Happy holidays.
Take care.
Bye.
Happy
Everyone,
holidays.
guys.
So
Bye.
Out January 7th. See you.